Good evening, everyone, and welcome again to a Tuesday night. It's 7th of July. It's just gone 8 p.m. My name is Faheem Shakur, your regular co-host for this MEDtalkx show on Pendle 103.1 FM. I'm with my regular co-host as well, Mehran, and also a special guest who Mehran will introduce very shortly as well. Usual thing is obviously today's topic is on falls, frailty and fatigue, the three Fs as I call it. Our studio number for any questions is 01282 723 455. I repeat, 01282 723 455. And if you want to WhatsApp a question, the studio WhatsApp number is 075 227 23455. I repeat, 075 227 23455. I really look forward to this evening's lecture, presentation, conversation with our dear friend, and I'll hand over to Mehran for the formal introduction.
Thank you, Faheem, and thank you for everyone for tuning in. It's the same time, same place, 8 to 9 on a Tuesday, and we've been graced with Dr. Akpan. Is it okay if we call you Asan for the next hour?
Yes, please do.
So Asan, he's got too many qualifications for me to reel off, but he is a visiting professor at the University of Cumbria. He's an honorary clinical associate professor at the University of Liverpool. He's also a community geriatrician at the University Hospital Liverpool. Also, I'd like to make a point that Liverpool are indeed Premier League champions. Way hey. He's clearly very much involved in research. So he's the aging specialty research group lead, as well as being part of the clinical research network in the Northwest Coast and chair of the Mersey British Geriatrics Society. So you have many hats, but we do welcome your presence. So thank you for coming, Asan.
Thank you.
So as Faheem introduced, the topic of three Fs. This has probably been present for a long time in terms of the need for clinical support. Obviously, as yourself as a geriatrician, have you noticed any change given the current circumstances with the pandemic?
Yes. I would first of all like to start off with saying that most older people live to a ripe old age and live very active, healthy lives. As healthcare professionals, unfortunately, the ones we come across obviously are the ones who have challenges and problems. So sometimes our view can be very skewed, and we, especially our junior colleagues, can think that all older people are frail, tired, and actually I have seen a few who do skydiving and all sorts of things that even I couldn't have the courage to do. So that's the first thing to start off with. Most older people live to a ripe old age now and live very active, healthy lives. Yes, so this pandemic that came out of the blue, while affecting obviously everybody, has had a greater impact on older people because they've had to have special considerations and have had to limit themselves because of the risk that when they do get it, they actually get very ill, and it can be very serious when they get it. So yes, it has had an impact on them in terms of reduced physical activity, which we can discuss later.
So when someone says someone is frail, it's obviously, as you've said, we have to try to stay away from generalizations. But it's also working in hospitals, the issue about long-term care as well as immediate care, about advanced care planning. It's something that's been very difficult to approach, isn't it, as always?
Yes.
And obviously you use frailty as part of a measure to try and base a decision on what that means when they're in hospital.
Yes. So that term frailty, again, honestly, most older people don't like it. But when we use it as clinicians, we immediately understand what we mean. So it's more of a medical jargon that we use so that when we discuss amongst ourselves, we understand what we're talking about. So apologies to all older people. But if we come up with a better term, I'm sure we'll be quite happy to use it. But for now, when we talk about frailty or people being frail, we are referring to people with reduced reserves to be able to withstand any stress that comes their way, whether that's a physical stress like a physical illness or psychological stress like the loss of a loved one or friend. All this can have impact on someone, and especially when we're older. So frailty in a nutshell just refers to reduced physiological reserves to be able to withstand any stress that comes our way. And as a result of that reduced physiological reserve, older people tend to take quite a knock when they get ill. And there have been many times on my ward round when I have distressed children, sons, daughters coming to me and saying, "Oh my God, my mom, she's just had a simple chest infection, but she looks so different. She looks so weak. She's confused, she's disorientated, and it's taking her a long time to recover." And that's just because there's that reduced physiological reserve. The reserves are not there anymore to fight and respond like people could when they were younger. And that's what happens. But fortunately, with good treatment, people respond. They might take time to recover. And just like I had a clinic consult today, there was a gentleman that I looked after about 2 months ago. He had a severe illness, and he needed a Zimmer frame. He needed lots of support. But 2 months down the line, he's back to his usual self. He was able to hold a good conversation with me. He remembered, what was going on. He could remember, but he's fully recovered. A younger person, they would just bounce back in 24, 48 hours, but for some older people, especially if they've got other medical conditions, it can take quite a while. So that's sort of frailty, a concept that we've become more familiar with over the last sort of 10 to 20 years.
Excellent. And Asan, in terms of your job, you mentioned the ward rounds and clinics. Just for the uninitiated and our audience, can you tell us what you, as a consultant geriatrician, what is your Monday to Friday routine? What do you do?
Okay. Well, I can talk about my role, which is a bit different from the standard roles that people are used to. And I can also discuss what other geriatricians do. My official title is a community geriatrician. And what that means is that I spend most of my time outside of the hospital, actually. So I only spend maybe a day at most in the hospital just to keep in touch with colleagues, not to become rusty. And also have that camaraderie with my colleagues, so that when I call or want to admit somebody, I've got those relationships still going. So that's key. So spend about a day in the hospital, and I spend it on a special ward called the Frailty Assessment Unit. This is a special unit that's been purpose-built so that all older people with frailty are channeled into that unit. And what we do is we work in a multidisciplinary fashion. So we have therapists, we have social workers, we have nurses, we have healthcare assistants, dietitians. We all see the patient very rapidly, and within an hour, we've got a working diagnosis, and within the second hour, we're implementing the clinical management plan. And most patients, between 60 to 80%, get discharged within 24 hours. And the remainder might take a few more days. These units are not unique to my hospital now. They are widespread, and most hospitals now all over the country have seen the benefit of having a unit which is purpose-built for an older person. So it's not a noisy environment. It's wide, spacious. You have all the clinicians that train to look after older people, so they know the needs of older people and how they can support them. So that's where I spend a day a week, usually. And then 2-3 days a week, I'm out. In pre-COVID, I was out visiting people in their own homes, doing the assessments that we normally do in the clinic. I would be doing it in people's living rooms or in their bedrooms. And for those who live in care homes, especially nursing homes, we always go and see them in their care home, because it's just much easier for the person and for the care home, rather than getting them to come to us. And also we get a lot more information, richer, detailed information, if we see people in their place of residence. In addition to that, I have multidisciplinary meetings with the community matrons about the people that they also see and look after, usually cases that they're not quite sure which are complex and they might need some advice from me. So once a week, we have a meeting. These are mainly around care homes, but we also have patients who are not in care homes, but the community matrons might wish to discuss with us. So I usually participate in those multidisciplinary meetings. All of these meetings now are virtual, so we use Skype or Zoom or Microsoft Teams for it. So we're still able to provide the clinical care and support to our primary care colleagues and to the care homes for these patients. And then for 1 day a week, I have time allocated. My employers have been very kind to, participate and contribute to academic medicine. So there, I do lots of things. I sort of collaborate with various groups who are interested in doing research in older people, but I also support medical students who are interested in doing research or writing publications and review articles and showing them how to do it and supporting some of them all the way. So do various things there, but that gives me a good mix and keeps me from getting bored and out of trouble.
Definitely keeps you on your toes, all of that, what you're saying.
Yes.
In terms of the frailty that you mentioned, I was reading an article just last week in the Lancet, and the authors there mentioned that frailty is as important as just age, in terms of actually taking into account for the COVID pandemic. So they're looking at it as an independent risk factor. Generally, people have looked at underlying health issues and age, but they actually said that frailty is that something that you've noticed?
Yes. So I can understand how they've reached that conclusion, which is right. So for many years, but many years ago now, age alone was used as a marker. But as I said at the beginning, there are lots of older people who live to a ripe old age and are quite active. So age is not a good marker to make decisions, especially when you want to decide about interventions, people who might need surgery and all that. So a better way of assessing that is, what is the disease burden for an individual? What would be their response if they were stressed? And that concept of frailty, where we know there's reduced physiological reserve, and depending on your stage, whether you're mild or severe, we know how you might respond if we were to give you some treatment, or if you were to have something like surgery, or if you were to go into intensive care, whether you would do well. So frailty as a concept has been very useful, because we know that people who have severe frailty, those who have severe frailty, we know usually have about 12 months or less to live. They won't be around much longer. So they are quite, their physiological reserves are quite low, and therefore any intervention has to be thought of very carefully, because it might actually cause harm and shorten their lifespan. And in the same way, they are unlikely to respond very well to surgical intervention or to a stay in the intensive care unit. So usually we have to be very careful and review those who have severe frailty and have a discussion with them and their family about the likely outcome, so that we can come to a decision amongst ourselves. People who have mild frailty and those who have moderate frailty usually would do reasonably well with most interventions. But again, we usually have discussions, and sometimes people decide that they don't want to go down a particular route, which is fine.
Yeah, no, frailty is a very big topic, isn't it? As obviously right to. So for listeners and viewers, if the concept of preventing frailty is talked about, I think NHS England have released a document just referring to simple things, actually, just about the importance of looking after your eyes, looking after your bowels, making sure you attend your regular screening programs, hydrating yourself, keeping active. Are there any other strategies that you would advise people to ensure that they live well and age well?
Yes. So I think it starts from the time we're born, actually. This we're now looking at things more like a life course rather than when we get to 50 and thinking, oh gosh, like me, I've hit 50 now. What's happening? What am I doing? Do I need to do more exercise? So it's really right from the very beginning. Yes. We want to encourage physical activity. So keep that Xbox locked, release it maybe for a few hours only if they've done their homework. Encourage a good healthy diet. So, popping a lot of soda drinks down, maybe not so good. Too many chocolates, maybe not that good. So a balanced healthy diet, good way forward. Physical activity, engaging the mind, so right through the life course, right from the time people are small, young, up to the time they're getting into middle age, and then if they do that, then there are many things you're going to prevent or reduce or prevent the onset, including frailty. So we encourage everyone to start as soon as they want to, as soon as they start thinking of this. But there is this saying, it's never too late. So it's true, it's never too late. So it doesn't matter what age people are, we encourage them, do something, any physical activity. We're not saying you have to do 5 miles in under 10 minutes. No. If you are doing nothing and you start doing something, that's good. And then just keep on pushing yourself at a pace that you are comfortable with. We wouldn't want someone to become unwell because they overdid things. But whatever you can do is good. So physical activity, great. Reasonably balanced diet is good. A certain stage when we get to our life, and it doesn't really matter what we eat, but a healthy balanced diet is good. If you take too much of anything, you will get unwell, whatever it is. So a good spread is always good. I'm saying all this obviously, but also being mindful that not all of us are fortunate enough to be able to make some choices about physical activity and a healthy balanced diet. So that is an issue. And it's one of the things I am interested in as a researcher, researching social and health inequalities. So I am saying this, but being respectful and mindful that there are people in our country, here in the United Kingdom, one of the richest countries on the planet, where they're not in a position to actually choose a healthy lifestyle.
That's excellent. I know that this segment is probably much completed then with frailty. I want to move on to the fatigue part of the show, and what better way than a few questions that have already come through, Asan? Okay.
Oh, cool.
So maybe if we can introduce the topic of fatigue through these questions and your answers. What are the
Sure.
causes of fatigue? Is vitamin D important to tackle fatigue? Obviously, vitamin D has been in the airways and the TV for quite a long time now recently. And are there any vitamins or minerals that can help against fatigue? So a little bit about fatigue, vitamin D, and any vitamins or minerals that you might suggest.
Sure. Okay, so fatigue is one of those vague terms that we all talk about, and we think we sort of know what we're talking about. The people that are reporting fatigue to us as healthcare professionals also have their own. People mean they are tired, they are exhausted, and sometimes when you go through the usual things that you may not come up with any particular cause, but what you might find is there are many things that might contributing to it. So in my clinical experience, usually people who complain of fatigue will have a variety of medical conditions, and this could be anything, because that in itself is reducing people's physiological reserve and makes them tired. But also, you mentioned a lack of certain vitamins, and vitamin D. Yes, if you are low on vitamin D, you will be tired, you will be weak. It can affect your muscles and affect your ability to do things. So that is an important cause. And as you are aware, it's not uncommon in older people with vitamin D deficiency, especially in this country with our climate and things. And in some subpopulations, like in our Asian community, vitamin D can also be very, very low. So it's not something. It is important, and I would advise people to be thinking about that, and they can ask for a check, because that's something that can be easily treated. In terms of what we can do to try and prevent fatigue, again, I would say just general lifestyle advice, taking care of your various medical conditions. So if we've got diabetes, again, adhering to some of the advice that we're given about the diet, trying to make sure that we keep our blood sugars within a normal range, getting that physical activity in, in a step-by-step manner. And that's sort of the general advice I would give. But yes, when people encounter healthcare professionals, they can have some more detailed investigations to look at the causes. But usually it's not just one thing. Usually it's a contribution from several things.
And that's the key thing, isn't it? Trying to get a very holistic, a very broad perspective of that individual to try and understand, because we do know mental health problems do exist and coexist with fatigue to various degrees. And the importance is that sometimes individuals may have repeated number of investigations, but it hasn't come back with anything significant. But certainly they still feel the fact that they're very tired, and the fact that they're tired, it's a self-perpetuating feeling that everything's quite negative, and just further burdens their mental health and further potentially isolates them, because the key thing is that you want to interact, you want to stimulate yourself, you want to have a purposeful life. But if fatigue is present, and despite a number of investigations, it can be quite a negative period, can't it, during the whole process?
Yes. Thank you for reminding me now. You see, this is why I love the discussion. 3 heads are definitely better than one. One of the significant symptoms of low mood depression is actually fatigue. People just feel exhausted. They feel tired. They can't get up in the morning. They just don't want to, and sometimes when people tell me that, I then try and ask specific questions to see if they've actually got the other features of low mood or depression, because it could be, as you've said, you have all these investigations for a physical cause and you turn up with nothing, but it could be a marker that maybe there is something else going on. So very good point. Yes.
Excellent. And in terms of fatigue, can you just impress upon the audience that it's more than just feeling tired, isn't it, Asan? Because it's, we all feel a bit tired now and then, don't we? But it's an actually process of really, like you said, not being able to get out of bed physically. Is that what you see? And is that how it presents to you?
So it can range from just, again, the term is vague because there isn't any actual agreed definition for fatigue. People give it various definitions, but broadly speaking, it can range from just simple tiredness, but most people will not report transient tiredness. Where people report things is where it's chronic, it's been going on for weeks, months, and they just are not getting any better. So I would say weeks to months is usually what you get told by people. People understand that if they've had a poor night, they've not slept well, they'll be tired the following day, or if they've done more than they normally, if they've overexerted themselves, that they'll be tired. People obviously get that. But this is where they cannot put a finger on, why am I so tired? Why am I, it's been a few weeks now, or it's getting to months now, what's going on? Or it may be their relatives or their friends who say, oh, let's go play ball, let's go do this, and say, oh, I'm tired. And then they start that's when you get to hear this, and then you have to sort of try and investigate and get to the bottom of it. And if there is no physical illness, as has been rightly said, we need to think of other things, psychological reasons, is there depression setting in? Has something happened? So lots of things to think about.
Yeah, and I think NHS UK have given some quick wins, isn't there? Just because fatigue and tiredness sometimes can go hand in hand, and as you said, there's no clear definition, there's no clear demarcation as to which one's which. But you know, if it's about your diet, if it's not good, or you're not eating as much and you've had unintended weight loss, then sometimes eating often and small amounts can be helpful. The other thing is about increasing your levels of energy, so moving, and that will help you also lose weight, which can subsequently help you gain a lot more energy and that kind of endorphin rush, which we do see a lot. Given the current circumstances with the pandemic, I do see a lot of people now going out, exercising, using that opportunity to, improve their well-being, or at least it feels that way. And we can't forget the importance of sleep. But fatigue can sometimes worsen or make you feel as though you need to sleep more. So there's a very fine balance, but there's lots of advice around sleep hygiene, which certainly your general practitioner or other physicians involved in your care can obviously support you with.
Yes. So yes, you're right. When people complain about fatigue, we usually try and go through a very comprehensive history. We go through what they do during the day, how when do they go to bed, do they have to get up several times at night, and sometimes we know that the older we get, especially for men, if they have prostate problems, they might have to be going several times to the toilet, and they may not be aware of that, but then it interferes with their sleep and they don't really rest well, and then the rest of the day, during the daytime, they're sort of tired. So you go through a history, trying to understand what people do in their daily lives, what's happening, then go through their various medical conditions to see whether that could be contributing. And then when you're still hitting blanks, then you can do some blood tests, including checking vitamin D levels and other vitamins. And as I said, usually it's unlikely to be just one thing. Usually you find a few things and then you try and work with the person to address them. Yes.
You're getting a lot of questions, Asan.
That's good. I like questions. I like questions. I learn when I get asked questions.
So, I mean, one of the topical things people are talking about is the post-COVID survivor. They're quite fatigued and tired, aren't they? So maybe you could perhaps talk about your experience, about what they've been feeling and how you've been counteracting that. And that sort of will cover one of the questions. And just the other thing that I want to talk about fatigue with you is fatigue and driving, because I find that's quite a bit of a issue in terms of safety for the general public. So maybe you can mention about getting tested if you're struggling to drive and you're feeling fatigue. There are certain conditions, aren't there, that they need to exclude. So a little bit about on the post-COVID experience in terms of tiredness, and a little bit of tiredness and driving.
Okay. So COVID is interesting in that it's almost like every week, every month, something new is being published and being found about it. But one of the things that's coming clearly across is that there are people who've been significantly affected to the extent that they are, as you said, feeling tired, exhausted. They are not able to do what they used to do before. And we are, I don't know whether this has hit the news yet, but I know in various parts of the country, quietly, they are beginning to set up rehab units in preparation for what, unfortunately, we're worried about, that there are going to be lots of people needing medium to long-term rehabilitation to get them back to where they were before. So in my patch, we are already thinking of having a 300-bed type facility, not just for my local area. It will cover a bigger area to try and support the existing systems to help with the rehabilitation. In the short term, what we are doing is our therapists are giving people advice and leaflets on what they can do within their own homes. As I said, if you do something rather than nothing, that's good. That's good. So you can lift your arm, you can lift your leg, you can do something. So the therapists are working with people who have difficulty, various levels of difficulty, and identifying what they can do in steps and in stages that's safe for them, but also that would keep those muscles active, because we know if they don't get used, it just gets deconditioned, and then when the time for rehab comes, it may either not happen or it will take a long time. So those are some of the things we're doing in the short term. I don't know how, I cannot say how big the problem will be. We're hoping it won't be, but if it is, I think from what I can see, there is preparation going on so that we can support people.
And just the other thing about driving, Asan.
Oh, yes.
Yes.
So, yes, I mean, generally speaking, if you're feeling so sleepy that you're actually dropping off, then obviously that's not safe. It's not safe to drive. I mean, we've had incidences where people have slept off and crashed, so that's not safe. So my advice will be, if you're already feeling very sleepy at home and you're noticing you're nodding off, then it probably is not safe to drive. You would have to go and have a discussion with your primary care clinician, whether that's a nurse or a doctor, and just have a discussion so that you can be reviewed, your medical records and your medical conditions can be reviewed, and if there are any additional tests that need to be done, they can be done. So certainly, yes, I think if you're sort of not able to control things and you're sort of nodding off, it's certainly not safe to drive, because it's not just you, but other people who use the road, including pedestrians, who would be at risk.
Yeah.
Excellent advice.
Yeah, no, as you alluded to, Faheem, there's obviously a list of disorders, aren't there? As an all-day psychiatrist, unfortunately, I do have to have those uncomfortable conversations because, let's say, for example, dementia, it's a notifiable illness, so you have to let DVLA know. But that doesn't mean that someone has dementia, they can't drive. So that's the key thing. And if clinicians are there listening or viewing this, if you're not sure, there are driving assessment centres there which you can refer people, and obviously speak to other colleagues in terms of what the risks are and try to get further understanding, because attention and concentration is one of those areas about your ability to drive. So yeah, no, fascinating discussion so far. I think we can use this opportunity to have a quick 3-minute break. We're getting lots of questions coming through, so let's keep them coming. And we'll see everyone shortly. Thank you for listening.
Okay.
Thank you so much.
Thank you.
Right. Welcome back, everyone. Just had a quick break, and questions have been flying in. So let's start with one from Shazli Azmi. So she has said that, how can I improve post-viral fatigue at home? Kind of touches what we talked about earlier, but maybe there's a bit more about the bounce back ability. What else can you do about post-viral fatigue?
Yes. So I think the most important thing is not to give up, because sometimes when we get so tired, we just don't feel like doing anything. And as I said, doing something, anything, is better than doing nothing. So initially it's going to be tough, and I wouldn't suggest you try to overstretch yourself, but just set some targets that are easy to achieve. So I don't know your circumstances, but all I'll say is just try and do something that uses all of your muscles or some of them. And then once you're comfortable with the stage you've reached, then you can step up from that and move on from that, and just do a little bit more each day until at the end of the week and at the end of the month, you'll be surprised how much you'll be doing. Because what's happening is you're stimulating your muscles, and therefore they will respond. If you use it, they will respond. If you don't use it, they just get weaker. So to me, it sounds simple, but I know it's not easy, and it can take a while.
Excellent. Well, we've been covering, obviously, so far fatigue and frailty. But Asan, I really want to concentrate now on falls for the last segment of the show with you.
Yes.
Falls are obviously a very common complaint that we see in primary care and just generally in the NHS. There's actually particular falls clinics that are set out there to try and help with this. Can you actually try and explain to people out there what are the common reasons that you see for people falling and what they can do to try and prevent it in the home?
Sure. So the commonest actually is environmental hazards, the things that we have in our homes. So our rugs, our nice carpets, our wires, clutter generally. It's always interesting. I always have a great time when I visit people in their own homes. I'm able to see straight away why people are falling. So I would say that's usually number one, because these things just happen over the years, isn't it? We add something, we pile this, we put that there. It's amazing what can pile up. I mean, I've during this COVID, I've been doing a lot of clearing out myself, and I was just amazed at what I was keeping. So environmental hazards, certainly, wires, rugs, and sometimes the flooring may not be right, and what we're wearing. So sometimes, for example, depending on what slippers I'm wearing, and there might be a little bit of water on the floor, and I've found that I've slipped. So those are the things to think about initially. And once we think we've sorted out our environmental hazards, then the commonest other reason for why older people especially might fall is, again, as I said, when we get older, things are not as sharp as they used to be. So our reflexes become impaired. Our ability to respond when we stumble becomes impaired. And where we could easily right ourselves if we made a little stumble and be okay, it may not be the same when we're older. And we might find that we're off and going straight on the ground. So those are some of the things. And then if you want to be a bit more clinical, medical, by the time we've sort of sorted out that it's not an environmental hazard, it's not in an impaired reflex, because you don't have things to hold on to. When we start looking at clinically, the commonest cause of why people fall is actually us as doctors, the medicines we prescribe. We sometimes prescribe so many medicines to older people, and sometimes we don't check on them as they get older. So someone in their 50s might be okay with what they are, but by the time they are 80, they probably are not. And they probably need a dose reduction or 1 or 2 tablets stopping. And what these tablets do is they can lower the blood pressure, make it go so low that not enough blood is flowing to the brain, and people will feel dizzy, lightheaded, and then they can fall. So when people actually get admitted to hospital or are referred, that's sort of clinically, that's usually the commonest reason. And we always look at the medications and why. So I would say environmental hazards, impaired reflexes, too many medications. We need to review the medications. We need to ask our nurse or doctor, please, can you just check, are these medications too strong for me now? Especially if you were prescribed tablets for hypertension in your 50s and no one has actually had a chance to look at them or review them, they might be getting a bit too strong and they might need it to reduce the dose or actually stop one or two. There are many other courses, but I would say those are the key ones that I would share with you to think of, because if we address that, actually, we would address a lot of falls. And of course, I'm sure we'll come to how we can manage it and we can discuss how we address some of these things.
So what would you advise people who may have had a fall or who went to see their relative and found out they actually had a fall a couple of days ago? They couldn't really recall a great deal of what actually happened, but around the environment thought something isn't quite right. What would you advise for someone in that situation?
Okay, well, if someone doesn't actually remember what happened around the time they fell, then that is not straightforward. I would usually advise that they be reviewed by a nurse or a doctor or a therapist, because all of those three, nurse, doctors, they are quite good now at assessing falls and having a look. We know that if people faint and fall, they may not recollect what happened. So they might say, oh, I fell, but I just don't remember what happened. So it could be a marker that they might have fainted. So the nurse or the doctor or the therapist would know how to assess them. So apart from checking for the environmental hazards, examining their muscle strength, they will also check their blood pressure while they are sitting, and also when they stand up, to see if the blood pressure drops. Because if it drops significantly, then that might be a reason why they passed out. And then that might give a clue as to what might be going on. It could be the medications, or the person might need further investigations. But usually, commonly, it's just the medications that need sorting.
Excellent. And Asan, we've got a question coming in, and it's something I wanted to touch on anyway. And it said, is a lack of balance or poor vision a cause of falls? Can you talk about those two topics and their relationship to falls?
Absolutely. So the way I think about it is, what do I need to keep my balance and walk well and not fall? So I need my brain to function. So what are the things that can cause problems with my brain? Well, if I have my brain cells being destroyed by a disease like dementia, it can get to a stage where I'm not aware of the risk and I might do things that I may not normally have done and I'll fall. Then you come to your eyesight. Yes, again, cataracts, macular degeneration, things like that common when we get older, and therefore we might miss a step, we might miscalculate our steps and things and trip and fall. So that's correct. And since we're on the thing about eyesight, we also need feedback on where we are in space and time. So we need our peripheral nerves, the nerve endings at our feet, sort of to give us an idea where we are and our balance, and that feeds back to the brain and allows us to control our balance and mobility and walking, and that can be impaired. So patients who have diabetes, for example, or other conditions that might damage those nerves, it makes people unsure of where they are, and therefore if they stumble, that contributes to them not being able to quickly right themselves and they fall. So they're usually quite comprehensive assessments that are done by the therapist or the nurse or the doctor who actually sees someone who is falling repeatedly. And again, just like in fatigue, it's not usually one thing. You would find a combination of things, and all those things need to be addressed. So if there's poor eyesight, We will need to try and address that as much as we can. If the muscles are weak, we will need to put in place a good exercise regime to help improve the strength in those muscles. And some people might need support with various walking aids to maintain their balance.
I think that's important, isn't it? Because you also have the sensory team, for example, who can actually support you with what kind of aids or what adaptations you require, whether it's hearing or vision or both, because that can really impact your ability to communicate, to live, have that quality of life. So it's really using the community resources that exist. And I'm always mindful that we shouldn't ignore possible alcohol being a trigger. As well as other aspects, as you said, the list is quite long. So the clear thing we have to do is obviously consider every possibility and see what that means for that person. Because ultimately, you want them to be safe, but also you want them to have a clear, cohesive plan moving forward, so that they're supported in terms of living well, isn't it? That's ultimately our aim.
Yes. So yes, we are, of course, we want to do that, because one of the most severe injuries, of course, with falls are fractures, especially hip fractures. And we know that older people who have hip fractures, unfortunately, mortality is about 30%. So people, about 30% will die within 12 months of a hip fracture, with or without surgery. So it's not a minor thing, it's a serious thing. So really the key here is trying to prevent it from happening in the first place, because once you have a significant injury like that, you're unlikely to return to your baseline. And if you were walking without a walking aid, you'll probably end up with a walking aid. And if you're using a walking aid, you'll probably end up needing something a bit more than just one walking aid. Yes.
Okay. I know next week we've got Age UK coming along, which flows quite nicely with the topics today. But Asan, I want to get some advice from you regarding, say, personal alarms and telecare. Obviously, you work in care homes as well, and a lot of people, they might be scared of falling. And to reduce the fear, would you recommend these sort of aids nowadays, or not?
So, like everything else, it needs to be assessed whether you will benefit from it. Usually people who are at risk of recurrent falls, especially patients who may not be able to remember instructions, might benefit. But yeah, people who are at risk of recurrent falls. So there are various things. So of course there is the lifeline that people can wear around their necks, on their wrists, so that if they do fall, they can press and get some help. But over the last few years, things have become more sophisticated, and now I think there are available things. I don't know whether it's out for general use yet, but certainly in the research world, there are kits now that can sit in people's living room and can monitor things and actually sense when you've fallen, and then they can then send a message automatically to the designated person that you've chosen, so that they can then talk to you through that device and you can get help. But there are lots of other things that we do. So yes, we have a professional called an occupational therapist, who usually would come to someone's place of residence, and they'll just ask them to just go through what they normally do, and they'll observe them. They'll see where they are having difficulties and identify what adaptations can be made to make that home environment safer. And also sometimes the entry into the house and into the back garden, certain adaptations can be done, like a ramp, or railings on the stairs can be put in. Adaptations can be made in the bathroom and the toilet, so that people can get in and out more safely. And also in people's bedrooms, additional support railings can be put in so that when they are getting up, they can hold on to things safely. And so there are many things that can be done to try and mitigate the risk of people falling where we have not been able to resolve the problem. Yes.
Because the one approach is about active case finding, isn't it? I'm not sure, Faheem, in primary care whether you probably do this in terms of who's at most risk of perhaps having a fall, making sure they're on the right, the nutrients in terms of medications. Is case finding the best way to kind of preempt, or is there other strategies that you think we should consider? Because I don't think falls are going away.
No, they are not. They are not.
Yeah.
And as part of the, so in the primary care physician's contract now, they do have to identify those who are frail, usually those who have moderate and severe frailty. And as part of the risk assessment, they do ask about falls. And if they pick up that they've had 2 or more falls, then they will then ask further questions, trying to assess their risk of having a fracture. So you can, if someone has not had a fracture, then there are tools that the GP can use, called FRAX, that can estimate someone's risk of having a fracture. And if it's high, then they will be either given some treatment straight away, or additional tests might be requested to assess the strength of the bones, so that the appropriate medications can be given to try and keep the bones as strong as possible, so that if they do fall, the risk of a fracture is reduced. However, we know that if people are above a certain age, usually 75 and over, and have had a fracture already, then we usually don't put them through any additional investigations. We assume that their bones are not as strong, and they are likely to have a condition called osteoporosis. And the national recommendation is to straight away put them on treatment to strengthen the bones, which is usually a combination of a special drug that increases the strength and supplementing that with some vitamin D and calcium supplements. So that standard practice now has been that way for many years. But obviously, there are many people who slip through the net, and maybe we just need to get smarter and better, as you said, at case finding. At the moment, I think they are picked up if they have severe or moderate frailty. And I'm not aware of any specific national case finding program outside of that, but maybe that's something we should be thinking of doing.
Excellent. So I just want to touch upon that case finding, Asan, because that links in quite well with NICE guidelines and falls in older people, assessing risk and prevention, that came out June 2013, I think it was. And I think we've covered actually for the public most of the topics, but there is one I want to just, if you can say a few words and then maybe some top tips as we're coming to the end of the show. And that was urinary incontinence is also mentioned in that document. We've covered many other topics. Can you mention a few words for the public about incontinence problems as a source of falls, and then perhaps give us some top tips that you want people to leave with from tonight's show?
Sure. So this is where we have an accidental passage of urine when we don't really plan to. And when we get older, especially in women, the bladder muscle can become overactive. And the sensation we feel we need to go to the toilet. And if we don't get there on time, we might have an accident with the waterworks. So what that does is that people are then in a rush, are rushing to go to the toilet. And as I said, the commonest cause of falls are environmental hazards. So in that rush to get to the toilet, people will stumble, slip, and fall. And it's more common in the night when people are waking up, it's dark, not quite sure where we are, even if it's in their own home, because they are in a hurry. This bladder is overactive. It wants you to go straight away. You can't wait, you can't hold it. So people know that and then are rushing to get to the loo, and that's why they then fall. So that's the link, that's the association. So what we then try and do is to treat the overactive bladder. Obviously, you do the usual assessments, make sure it isn't an infection, because sometimes an infection in the waterworks can present that way. But more, I'm thinking of something that's not an infection. If it's an overactive bladder, then we can treat it. And then that reduces that, and hopefully prevents that person from falling. In terms of top tips, again, I'll go back to my, if you don't use it, you will lose it. Honestly, if physical activity was a drug and I had shares in it, I would be a billionaire now. Yeah. So it's free, and use those muscles. Even if you are not able to go out of the house, you can do something. Anything you do is better than nothing. Balanced diet as much as possible. Have a bit of something, a bit of that, a bit of that. Balanced diet. Eat well as much as you can. Don't drink too much alcohol. Don't smoke. This healthy lifestyle advice, if we all did it, honestly, that would do us a lot more good than the tablets that people like me prescribe for you. But if you do take tablets, then try and take them. If you're not sure why you're taking them, have a conversation with the nurse or the doctor so that they can explain to you why you're taking them. Because I think if you do know why, then you will probably take those tablets and you will keep your other health conditions under good control. Those are my top tips. If you did that, then I'll be out of a job and I'll be very happy. I've got other things I want to do. So no problem. Yes.
That's a lovely way to finish the evening. Any final comments, Mehran?
No, I think it's just, it's another whirlwind tour of various number of topics. But, and I know we didn't really spend a great deal of time in terms of your research hat on, but yes, the key thing is for the listeners is to be involved, especially if you are from a BAME background. There's additional incentive for you to be involved, because I think we need to start to shape and make sure whatever we receive in the future is tailored to our needs as well. So certainly that would be my point. But we've got a really interesting show next week for him. I think we're covering loneliness, aren't we?
Yes, we're covering loneliness. It's been in the news a lot, and that's with some representatives from East Lancashire, Age UK, hopefully coming along. And I think it ties in quite well from tonight's show. Just a warm thanks to Dr. Akpan Asan for coming and sharing your insights. The hour's really gone very quickly, and it was really quite stimulating and interesting, I'm sure, not just for us, but everyone listening in. We really needed 2 hours, I've been told by message, to cover everything. So I think that gives you an idea of how well it's going down. I do hope you'll come back another time and join us, Asan.
No, thank you so much. I've had a great time. Thank you.
That's great. Thank you for coming.
Thank you.
Take care.
Take care, everyone. Good evening, everyone.